Hello, everyone. We'll get started in just one moment. Okay, I'll go ahead and get us started. Hello, everyone. Thank you for joining us today. I'm Bethany Burkhardt, the Director of Operations at Allergy and Asthma Network. I'm excited to welcome you to this afternoon's webinar. We have a great session planned, and I'm pleased to introduce our presenter, Dr. Hogan. With her extensive knowledge, we can look forward to an enlightening session. Before we begin today's program, I'd like to cover a few housekeeping details. First of all, attendees will remain muted during the webinar to minimize distractions. We will record the session and upload it to our website later this week. You can access all of our recordings on webinars at allergyandasthmanetwork.org. Scroll to the bottom of the page and access past webinars and future events. Our webinar is scheduled to last 1 hour and will include a dedicated Q&A segment. Although we will answer questions at the end, please feel free to submit them at any time using the Q&A box at the bottom of your screen. A team member will monitor the chat for any questions or assistance you might need. We will do our best to address as many questions as possible before we conclude. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology, ACAAI. ACAAI offers continuing medical education credits for physicians and attendance credits for others. You can create a free ACAAI account to earn CME attendance credits for Advances webinars via the member portal. I will put that in the chat. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you will receive an email containing supplemental information and a link to download your certificate. Okay, let's get started. Today's presentation is titled Effective Patient Education for Asthma Inhaler Instructions and Action Plans. In this webinar, Dr. Hogan will discuss the importance of patient education in asthma management and control. She will offer practical insights and describe correct technique for common inhaler types and identify frequent patient errors. It is my pleasure to introduce Dr. Angela Duff Hogan, the chair of the American College of Allergy, Asthma, and Immunology Asthma Committee. And she has developed initiatives such as the VA Asthma Action Plan for Children. She's a frequent regional and national educator covering topics such as asthma management guidelines and smart therapy. Dr. Hogan is a key healthcare provider and director for Fair Neighborhoods Initiative, providing educational resources and interventions to reduce healthcare disparities, especially in historically marginalized communities. This initiative was recently awarded the McCone and Joan Brock Virginia Health Sciences at Dominion University and CHKD Award. Dr. Hogan is a founding member of the Coastal Food Allergy Support Group, which helps healthcare providers, schools, and families manage their food allergies. Dr. Hogan's significant contribution to allergy and immunology were recently honored with the prestigious American Academy of Pediatrics 2023 Jerome Glasser Distinguished Service Award. Her commitment to community service and education reflects her values, and she believes in healthcare equity, and her lifelong experience with asthma and food allergies fuel her dedication to making a difference. I'll hand it over to you, Dr. Hogan. Thank you for being here with us.
Thank you very much, and thank you all for taking time in your busy afternoon to join us. I think this is a really exciting topic, and let's get started. So, assuming that my keys are working, which that very second they did not, so let me go to the other way. All right, so the first thing that we talked about is the importance of the mission of the Allergy and Asthma Network. And they did that long introduction so that you already know about me. And I have no disclosures to give you for this particular presentation. What we do want to talk about is what our learning objectives are here. And actually, we focus so much on medication sometimes, we forget the other part of good asthma management, which involves good inhaler techniques. It also involves making sure that the patients can teach themselves how to do it, show it to you back, And also we want to make sure that they have a good asthma action plan. So those are the things that we're going to focus on today. And it really is very important because if you've read the recent headlines, I usually like to put it in perspective. This was a recent headline that was published this summer. And the actual story was that the father was sentenced to 4 years for manslaughter for the death of his 9-year-old child. The little girl had gone over to a sleepover and had an asthma attack the next morning. And the parents of the girl's friend offered to take her to the doctor, but the parents said, it's okay. We will take her home and make sure she's okay. Later that morning, though, she was actually found to be having significant distress. She couldn't even raise her arms. And so then she was taken to the emergency room and she was in the ICU for 7 days, but did not recover. And the biggest problem here was that her inhaler was empty. It did not have any asthma medication whatsoever, and it had been empty for a month. And the parents did just not realize that even mild asthma can have a very serious asthma attack, and that we need to have medication with us always. There was also another recent story that you probably saw on the news in June. In this particular story, there was a 22-year-old named Cole who his asthma inhaler went from $70 to $500. And because of that significant increase in the cost of his inhaler, he did not purchase it. And then 5 days later, he had a severe asthma attack. And although he passed on, there were some mistakes made, and that the parents were not notified that there was going to be a formulary change, and the pharmacy in their rush did not provide more options for this patient. I see lots of questions. I just want to check real quick. Can you all hear me all right? Are there any problems, Bethany, with
Yes, we
hearing?
can hear you just
Okay,
great.
they're just filing in those questions fast. All right, well, I just wanted to make sure there wasn't a technical issue.
Yes.
So what we know is that there are lots of stories in the news where not only do patients have difficulty getting their medications, but I'm sure you have lots of patients where there's formulary changes and they may not get the appropriate medication. And the bigger problem with that is they may be given a different medication that they don't have any idea how to use whatsoever. I don't have to preach to the choir here. We know that asthma is a very common illness. It is the most common chronic disease of childhood, with pediatric prevalence is about 6 to 9%, and adult prevalence is about 8.9%. The problem is that many patients with asthma are not well controlled. About 50% of kids have uncontrolled asthma, and we know that uncontrolled asthma actually has a lot higher healthcare related costs in addition to increased morbidity and mortality. Researchers estimate that in the next couple of decades, the cost of uncontrolled asthma alone will be about $964 billion. That's about $53 billion annually. And there's over about 1,700,000 emergency room visits in 2023 for asthma alone. So it really impacts the healthcare system. So anything we can do to help patients get better control and better understanding of their asthma is critical. And I don't need to remind you that on average, about 11 people die per day from asthma. And what's really important is that we have good principles for asthma management, and those have been put forth in both our national asthma guidelines and also in GINA, which you know is the Global Initiative for Asthma. And GINA, as you know, publishes an update every single year, and this most recent version came out on World Asthma Day in May. And the things that GINA really emphasize in this particular update is that it is important for the healthcare provider to communicate with patients effectively, make sure you listen to them and understand what their needs are. And we also need to make sure that we are optimizing symptom control, minimizing whatever therapies we use for the long-term risk of exacerbations, the side effects of the medications we want to have reduced or minimized also, and then ultimately our goals are to reduce asthma mortality. And in order to provide those things, we need for them to have an asthma action plan, and they need to know physically how to use their medications to get optimal asthma control. How do we know what's the best medication? Well, it sort of is what do we do from our vision of asthma medications. We could talk about asthma medications at a population level. Those are where our national formularies come in, what our national guidelines come in. We also know that asthma phenotypes are well described, and that helps us sort of select what might be the big starting point for an asthma medication. And it is important that we think about each step of the way, what is the most efficacious, what is the best effectiveness, what's the safety, and what's the patient's access to those medications. But as you know, the best way probably is to bring it down to an individual level to discuss those medications and the way that we want to treat the asthma with the patient. And we do that through a shared decision-making process. We want to know what are their preconceived notions about the medicines that they may have been prescribed. Oftentimes in pediatrics, there's still a significant fear. Patients are worried about that word steroid. They're afraid it'll make their child hairy or fat or moody or short. And so it's very important that we hear what their concerns are and then we address those concerns. And as we shared in those first two stories, having medication availability is very, very important. And the medicines that we give them have to be affordable. And then we need to pick a regimen where we're not asking them to do something impossible. Several years ago, when we did not understand inhaled steroids very well, sometimes we would layer on 2 or 3 different inhaled steroids twice a day, thinking that the more and more inhaled steroids that we gave them, the better control we might get and keep them from getting oral steroids. And certainly we've learned now that that probably was unnecessary and not the best way to go. But sometimes I had patients that might have been given 2 or 3 maintenance inhalers, and it becomes very cumbersome and they just didn't do it. And then ultimately, whatever we pick for our treatments, we want to make sure that we optimize environmental impacts of those particular treatment methods also for patients. This is directly from Gina. You've seen this circle. Basically, Gina says that every time we see a patient, we should review what's been going on with the patients. We should assess their inhaler technique and their adherence. And then we need to adjust those particular medications based on what they are able to manage and also evaluate whether or not they're having side effects and, again, that the medication is getting paid for. And so what I'd like to propose to you, sometimes having uncontrolled asthma may not be that we pick the wrong medication. It actually may be related to the method. And there is no one perfect inhaler that every single person should have. But clearly in this picture, you can see here, here's a young child who's not using any kind of a spacer device. So you certainly have to wonder, and look at his hand on top of the inhaler. There are lots and lots of issues here with this approved picture of how to use your inhaler from a website. And it clearly is not. And we know that when you have bad technique, bad things can happen. And actually, there's been some recent studies that show that actually most patients do not use their inhaler correctly. And also that most healthcare providers themselves may not know every single device that they prescribe, and they may not know how to use it correctly. So it's very hard to expect the patient to know how to use it if we don't know and that we don't show them how to use it. And then if you ask patients over and over again, do you know how to use it? They will say yes, because they've been doing it, and they may not recognize that they are having problems with their technique. And so I think it's important for us today to review that there are lots of medicines, as you know, from the Allergy and Asthma Network. There's our favorite chart. This is the 2025 version. And you can see there are many different devices and types of asthma medications that are available. And they all sort of have their special, unique ways that we should be using them. And so let's review first what are some of the major types of asthma inhalers. And then let's talk about how we would use them. So the major kinds of asthma inhalers, there's the traditional puffer that most patients refer to. This is the pressurized meter dose inhaler that we've had around for about 40 years. Then there are breath-actuated meter dose inhalers, and we'll go over that in just a moment. And then there are also dry powdered inhalers that depend on a capsule or the medicine dropping down, and then we suck in with a particular force. And then there are also some inhalers that we sometimes use in kids with asthma and adults, and those are mist inhalers. So let's go over these individually and kind of hit the most important points and the things you need to know about that. As I mentioned, meter dose inhalers have been around for about 40 years, and many brands of our asthma medications use this particular device. It does, however, require some coordination. You have to be able to press the top and suck in at the right time and be able to hold your breath and take a good deep breath in order to be able to get the asthma medication effectively. As you know, it contains an inert gas that helps pressure and move that dose forward. As you know, it used to have things that were killing the ozone, and the new versions now are supposedly more ozone friendly. They don't pack as much punch, but they still are pressurized and do deliver the dose. And each of the doses are importantly dispensed by pushing on the top of the inhaler. And as I mentioned, it does take a little bit of coordination to do it correctly. So let's review how you would do a meter dose inhaler with and without a spacer. So first, a little plug. Everybody probably would take this particular device better with a spacer. But at about the age of 12 and sometimes even younger, we get a lot of pushback from individuals who are like, no, I'm a big boy now, or I'm a big girl now, I don't need to use a spacer. So if they're not going to use a spacer, there's some important things we need to think about. So let's review how you would do it. The first thing you do, obviously, you need to take off the cap. You need to make sure that that space, as soon as you look into the inhaler, is not all gunked up with previous doses or something else. I have some bad stories about what else might have been in a particular inhaler. But anyway, in this particular case, make sure it's clean. You want to hold the inhaler upright and you need to shake it. What I tell my families is that they need to shake it up because it's like salad dressing and all the good stuff's on the bottom. And conceptually, they kind of hear that and be like, oh yeah, I've had Italian dressing. It definitely has all the good stuff on the bottom. If it's an inhaler that hasn't been used for a while or it's being used for the first time, then you need to waste a couple puffs, and that's obviously called priming, so that the medicine gets all the way through the device. Then what you want them to do is empty their lungs so they breathe out gently so that there's space to take the medicine. Then they put the mouthpiece into their mouth. Oftentimes it's easiest to put it between their teeth, but we tell them not to bite it. They close their lips around it to make a good seal, and they want to start to inhale slowly, but don't take all the breath in, then actuate it, and then finish taking the deep breath. So there's that coordination where you have to push and suck at the same time. And then they hold their breath for about 5 to 10 seconds. Many resources say 10 seconds. And then while they're holding the breath, many times it's good to pull it out of your mouth so that you don't have that little space left in between the corners of your lips where the medicine can go out. And then you breathe out gently away from the inhaler because you don't want to get extra moisture inside the mouth of the inhaler. And then if another dose is needed, you shake it up again and repeat those and place the cap. What you can notice here on the side is a video link that you could go ahead and look to see if that video will help you teach that inhaler a little bit better. And then the next thing that we're going to talk about is what are the mistakes that people make with the meter dose inhaler. Well, the first thing is that they forget to shake it, which is something that, or they don't shake it very well. It's kind of a side little arm and then they're done. Certainly we want to make sure that they hold the inhaler in the correct position and not upside down or some other way. We do want to make sure that they exhale so that they can get a good deep breath. We don't want them to exhale into the inhaler. And then that coordination part, that they don't actuate the inhaler quickly enough. And so because they don't actuate the inhaler quickly enough, then they may not get the good deep breath and timing. And what we know is that if you don't time it right, you don't get the full dose. And again, sometimes they suck in just way too fast, and then they don't get the full dose either. And multiple actuations, you should repeat the dose, do the priming, or not mean the priming, but do the shake, and then do the puff. We don't want to do puff, puff, and suck in. And then the other thing is what happens when the inhaler's empty. And probably all of you all know that many of them have dose counters on them, and sometimes people don't understand is that that dose counter is there for a reason, and the inhaler is empty, it really is empty. So now let's talk about what would be the correct technique if you were using the inhaler with a spacer. Again, there's a video link there on the side of the screen if you'd like to go out and watch an actual video. What we know again is you need to shake the inhaler and prime if it hasn't been used in a little while. You put it on a little rubber ring that's on the end of the spacer device. Many times we tell kids not to slouch, sit up tall, or stand up if you're going to be giving the medications. And we tell them to breathe out completely and empty their lungs again, put the mouthpiece in their mouth, close it around it. Again, we want to time the puff, but they get a little extra time by having the spacer device so they don't have to be quite as coordinated. Some of these devices actually squeak or make a noise if you breathe it in too fast. And so we tell individuals, if it makes a noise, you did it too fast and you need to repeat it. And then again, when it's all done, you need to put a cap back on the inhaler. And that is an effective way. What I want to remind you about is that zero really does mean zero. And I have to tell my patients that lots of times because I have seen sometimes that patients say, well, about 60 puffs still come out of my inhaler in spite of the fact that it's on zero. And that means that's still just the propellant and it actually isn't actual medication that's still coming out of it. So it's not a bonus. Fortunately, some of the devices actually mechanically lock down. So once it's on zero, you can't get any extra puffs out of it. And you can see those listed here in the table, the ones that actually do lock down. But you need to remind them that zero actually does mean zero. Now, what about a spacer holding chamber? Spacer holding chambers are very helpful in individuals that are younger, that may not even still be able to coordinate using a spacer with a mouthpiece. What we know with these particular, or elderly individuals too, don't let me forget that. And there is also a QR code here that'll take you out to a video from the American Lung Association that will show you how to use this device. What we know is that holding chambers actually reduce oropharyngeal deposits of the medication. It also allows for more time for the patients to inhale, and it also eliminates some of that need for the hand-breath coordination. And it is very important in really young individuals who cannot seal their mouth very well around the mouthpiece that we get good coverage of both the nose and the mouth with these particular devices, and they can be very, very helpful when we are doing it. And the way that we would use this particular device is, again, we would shake the inhaler, we would take the cap off of it and put it in the rubber end again. We would cover the mouth and nose, and then we would push the puff. Inside of these usually is a flap that is going to move and let you see the breath. And most people say that you want to see them take 6 regular breaths, and then we get the medication into our lungs. And then at the end of it, we want to clean the device. Sometimes in kids, we do see, because of this particular device, a perioral dermatitis. Those are little red bumps that we see sometimes around the mouth when the inhaled steroid gets deposited on the face. And so sometimes we recommend that you wipe the face with a cloth or a washcloth after they've had their dose. And that can sometimes reduce the risk for a perioral dermatitis. The way that you should wash your spacer, probably the easiest thing, is to put it in warm water, dishwashing soap. We recommend not actually to rinse it, because if you leave that soap film in there, it actually can be helpful in keeping the particles from sticking to the side as much. We usually recommend that you let it air dry and then reassemble it. And some actual spacers say that you can put it through the dishwasher, and that could be helpful also. And then we're going to move on to the next kind of an inhaler, which is a breath-actuated inhaler. And the breath-actuated inhalers are breath-actuated MDIs. And so they still have a propellant-based aerosol in them, but they also don't really start until you actually actuate it with your breath. And there are 2 main forms on the market. There's an albuterol form of this particular breath-actuated MDI, and there's also a form of beclomethasone that uses this particular device. And this device is really good for patients who are struggling with timing And they still do get the additional benefit of an aerosolized medication, though, and they don't have to have quite as much effort as you need when you use a dry powdered inhaler. So this would probably be very helpful for those people who can't generate a really strong and rapid lung volume in order to get their inhaler. There's a high reproducibility. The same amount of medication is delivered with this particular device. And these devices do not need to have priming, and they don't need to have any shaking done before you use them either. So those are additional points to remember for these inhalers. And then we are going to move on to dry powdered inhalers. And again, there is a visual here that you can see how to use these particular ones. These are breath-actuated devices. The person needs to take a quick, deep breath in order to create enough turbulence to transform the powder into more smaller particles and are able to get it into the lungs. These inhalers, you don't want to exhale into the device because you'll add extra moisture and you might make that device less effective. And you also want to make sure they are very sensitive to moisture, so you do want to make sure you close them and keep them in a dry place. And the effective way for doing these particular inhalers are making sure that you don't shake the device and that you keep it in the proper device order. If it's an upright device, you don't want to be tilting it left or right. If it's the one that we talk about, holding it like a hamburger, you want to make sure that you do keep it level so that you don't dump out the medicine and you get it effectively. And again, we want them to exhale, we want them to suck in and hold their breath, and we want them to take a good forceful breath so that they can get the medicine where it needs to go. And then again, we want to discard it when it's empty, and we also want to discard it when it's past the expiration date. And again, there are multiple links here on this talk and QR codes and videos that will help you if you need to demonstrate it to your patients. And then the other device that is very complicated for a lot of kids is if you have a device that actually makes a mist. And these particular devices, you actually have to put them together first. And then once you have them locked in place, you have to put the cartridge in. And then once you have the cartridge put in place, which does take a little bit of force, we usually recommend that when you put the cartridge in, use a hard, firm surface and push the cartridge all the way up. And then when these particular devices are ready to be used, we recommend that you hold them upright. We do a click until we hear the arrows, or we move the arrows until we hear a click. Sorry about that. And then we flip the cap open, we breathe out, and then we breathe the inhaler in. And that mist will happen and be able to go into your lungs. And then when the spray stops, then you're done with it. We usually recommend that you hold your breath for a few seconds. And then if you have another dose to take, then you take it, and then ultimately you close the cap. And again, there are videos that are available that show. In pediatrics, we don't use this device very often, but certainly adult patients do use these devices. The things that I want you to remember for your kind of mnemonic for how we should think about inhaler devices is we want to choose correctly, choose the most appropriate inhaler that we think the patients will be able to use either based on their age. We want to think about, do we need a spacer for that particular individual? And if we do need a spacer or a chamber holding device, do we need to use a mask so that they can get the medicine most effectively? And then what we want to do is try to avoid using four different devices, that they have to learn all the different techniques for those particular devices, because that becomes very confusing and they very quickly forget how to use which one, especially if they're not very good about taking their medication. Then what I would challenge you to do is that every time you see them, you want to make sure that you review their inhaler technique. And it doesn't necessarily have to be you. Perhaps maybe you have a nurse in your office, or maybe you have an MA who's particularly knowledgeable about how to use the devices. But this is really an opportunity to make sure that they are optimizing their asthma therapy. So we should review the device, and we don't want to just kind of show them. Probably the most helpful thing is to ask them, How do they use their device? Let them show us, and then you can identify specific errors or problems or quick things you can change, like, hey, be sure and shake it up before you do it. And what we will find is that the payoff in the long run will be very important. And then it's important that we, as we teach these devices, do pay attention to where the problems are and the steps that we know and have seen other patients have problems with, so we can repeat that teaching as necessary. And again, in as recent or as soon as 4 to 6 weeks, people can develop poor technique for using the inhalers. So we want to review it every time we see them and have an opportunity. We know that the clinician should be able to demonstrate the correct technique. We want to make sure that somebody shows them along the way. And actually, there was a recent Australian study that showed 75% of patients using an inhaler for 2 to 3 years will tell you, oh, yeah, I've got that down. They use their inhaler correctly, but actually only 10% were actually using their inhaler correctly. And here's a prime example of a video that I like very much. It is from House, and I think we'll watch it for just a second.
Everyone's here for me. Shingles doesn't care, but shingles
With a little bit for shingles too.
is proven.
All right, here we go.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and twice as hard to fix them. You using your inhaler?
All the time. Go through one a week.
Sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
What was that all about?
You're making chicken recipes.
So I love that slide because, or that video clip, because it really does show that clearly she's been doing it wrong for a long time, and that's why her inhaler is not working. And as you know, she's probably not alone. There are lots of people who are not appropriately or effectively using their inhaler. So I've made a little chart here that may be able to help you kind of think about which age groups, what kinds of inhalers are helpful for different populations, and whether or not what some of the common errors are, and also what kinds of things that you need to take into account. So for example, if we focus on the infants and toddlers, those individuals are probably going to do best with an MDI, the traditional puffer. They're going to need to have a spacer that has a mask. And because they are just breathing and they don't follow instructions very well, it's important that we get a good seal around the mouth and nose. And it's important, if they're using it regularly, that we do clean that particular spacer so that we can get optimal delivery. And this particular chart here you can refer back to, but kind of reviews the different things that might help you select. Again, I think the most important thing is that whatever inhaler you use the most, that you feel comfortable being able to demonstrate it to your support staff so that they can teach it correctly, or that you are teaching it correctly too. Now, I used to have a lot of trouble with this whole concept of particle size. And so I just want to touch a second on particle size, because that was like all the rage about 10 or 15 years ago. Everybody was like, oh, it's not just about which medicine we pick or what device. It's all about the particle size. Where does the particle go? And that smaller particle sizes are super important to deliver the medicine effectively. And I just want to review for you particle size. We know if the particle is too small, then actually it's going to be exhaled or actually quickly absorbed into the systemic circulation. We think that if the particle is too big, it's going to get left in the mouth or the nose before it even reaches the lung. And we know that there has recently been a systematic review and a meta-analysis that actually says particle size really isn't that important. And in fact, GINA 2025 says there is currently insufficient good quality evidence to support the use of extra fine inhaled cortical aerosols over time, and that is really that much advantageous. So I think that we could sort of put that, at least in my mind, to rest. And that's sort of kind of out of vogue. Everybody's not talking so much about particle size. Really, what's more important is that the particles get into your lungs, and that's probably a much bigger issue than worrying about particle size. So, Gina says that the keys to self-management involve three main things. Patients need to have self-monitoring for their symptoms. They need to have a written asthma action plan, and then there needs to be regular review for their asthma control, their treatment, and their skills by their healthcare provider. And I think this fact was super important, that if we simply implement self-management in 20 patients, that we prevent one hospitalization. So for you, that might be a single day of clinic. If you make sure they understand how to self-monitor, they have an asthma action plan, and you review it and make sure they know when and how to take their medicines, you've prevented one person from being hospitalized if you were seeing 20 asthmatics. And that in and of itself says that's a huge impact that we can make. And there are actual studies that show there's significant reduction in hospitalizations, emergency room visits, missed days of work and school, and they have many fewer symptoms if we could simply implement these particular self-management keys. In addition to that, one of the things that is very important is that patients need to have an asthma action plan. And if you look, control F and look in Gina and ask Gina, how many different times does Gina in 2025 mention asthma action plans? It's 103 separate places in the guidelines do they actually talk about how important an asthma action plan is. And if we compare that to the NHLBI guidelines, it's 20 times. So I think it is important that we talk about asthma action plans, and they need to be written in a language that people can understand, whether they need it to be printed or digital or picture for some people that have lower literacy. It is important that they understand their action plan. And fortunately, with EMRs today, many EMR systems, you could type in what medicine they're going to be on, and then we can get a very personalized asthma action plan from the EMR system, and that's probably even more ideal. But we are going to take the walk down the electronic world of what's available online and see what asthma action plans are available. We know the importance of asthma action plans is that it is a guide to step-by-step management for the individuals of what they need to know about their asthma. It also gives you an opportunity to improve communication. I always go over my asthma action plan in the room with the family, walking through each particular zone. So it gives them an opportunity to ask questions and make sure that they understand. Because again, this is our opportunity to reduce utilization of the healthcare system, because they're getting earlier recognition of symptoms, and they're also feeling empowered that they're able to manage their asthma. And it's important that we have those available, obviously, in the school and community settings also. So I'm a big advocate of asthma action plans. So I have several asthma action plans available for you. Again, there are some QR codes that will take you out to those. And I'm going to review different ones and highlight different features that I think are important in asthma action plans. This particular plan on this screen is at the Asthma and Allergy Foundation of America. And what it does demonstrate is that there's an important first part of the action plan that identifies the patient. It also identifies who is the doctor that needs to be consulted if asthma isn't going well, and also emergency contact information is available. And that's usually the first part of the asthma action plan. This particular asthma action plan is what's available at the NHLBI, and it demonstrates well what a green zone is. And a green zone is the important plan that we share with the patient about what do you do when things are going well. It usually mentions what their baseline controller medications are, how often they should take it, and also what their particular dosing, is it 1 puff, is it 2 puff, is it 1 sup? And then it also tells them, how do you know you're doing well? It usually says there's things like no cough, no wheeze, no chest tightness. And then in some of those action plans, it may also identify what are known triggers for their asthma. This is usually the part of the action plan where it also talks about what do you do if the particular individual is at school and has exercise symptoms. and we want to make sure that they know how to pre-treat before exercise or how to post-treat if they are having symptoms with exercise. And that's usually what's included in the green zone. The yellow zone is usually what happens when things start to get a little bit of out of control. This is usually where we step up therapy. We tell them how many additional rescue puffs to take, or if there's someone who we want to accelerate their number of controller medication puffs, that will also be included in that. Sometimes there may be parameters that they monitor. Example, perhaps maybe there's someone who does peak flow monitoring, and those numbers would be there to say, hey, if your peak flow drops to this, then you may not be under very good control. So the yellow zone is usually the time that we can do an early intervention and hopefully pull them back up to their green zone. And then the red zone is clearly, we're in trouble. This is what we tell them to do. This is recognition of more severe symptoms. It tells them when and how to take their rescue medications. And hopefully there are clear directives that tell them when they need to activate emergency medical services and proceed on to the emergency room. And a good action plan, and they may label it some way differently, but pretty much the standard way now is looking at a green zone, a yellow zone, and a red zone, much like we look at stoplights. And here's an example of the action plan that is on the Quad AI website. It's also the SAM3 IMPRO, which is what the American Academy of Pediatrics reflects as their asthma action plan. And there's some additional things that are on a second page for this. And it also, again, does discuss peak flow monitoring. Peak flow monitoring is a little bit, for me, controversial. I don't routinely do it with most children unless they're very motivated. It is something that you can clearly not do a very good job if you want to get out of a biology test. And so in some populations, it can be very useful, but in children, there's the opportunity either not to perform it very well or to manipulate your results. We get a little better results, I think, with motivated adults in terms of peak flow monitoring. So lots of action plans don't have peak flow monitoring on them at all and really more describe symptoms. And again, these particular action plans, when they are being used for schools, want to have a place where the school staff can sign off that they have reviewed the action plan, they know what medicines the child has, and also gives an opportunity to say whether or not this particular child will be self-caring or not. In general, we think that in children that are remaining for after-school activities, like a sport or chess club or something else where the school nurse may very well go home, hopefully, then they should have an inhaler available, not locked up in the office when the office locks. So usually these these action plans will also talk about self-caring and self-administering as part of the action plans. So what do you do if a patient is on SMART or MART or AIR? Most of the other action plans really are very much focused on albuterol, or they have multiple lines that you can fill in. This particular action plan that is available on the Allergy and Asthma Network, among other sites, actually is specifically focused for individuals that are on SMART or MART or AIR. This was first developed in Australia. And in this particular plan, the yellow zone has become orange, but I think that's okay. Maybe Australians don't like yellow. I'm not quite sure. That's a joke. But as you can see here, there is what you do when you are doing well. And then as you start to have unraveling or symptoms of your asthma, then there is what is additionally added. And as you know, SMART, MART, or AIR use a single ICS formoterol inhaler. And we do that just a little bit differently than we did traditional action plans that had albuterol. And I'm just going to share with you a couple other ones. This is another one that is at the college website. Again, has ways to fill in, gives you a lot of opportunities and space to fill in medications and describe how we would like to use it. And then I'm going to share with you actually the action plan that we've developed for the state of Virginia. So in the state of Virginia, we don't have access as readily to EMR or the same EMR system for everyone across the state. There are a lot of healthcare providers that are on different systems. So we tried to develop a paper copy that actually incorporated both traditional usage of albuterol as a rescue and also smart Martyr air with using an ICS formoterol. And if you look at this particular plan, which we are currently using, there are two separate yellow zones there, one that uses traditional albuterol and one that uses what many kids do who are on smart therapy, who only have one inhaler that is an ICS formoterol inhaler. And so this particular action plan is being used across the state and available for all of our public schools. For those of you that make policies for your state, I think it's important that we start to merge both types of action plans and try to give schools guidance on when to use medications and how to use them, and following along the GINA guidelines for the number of puffs, and also what to do when their asthma starts getting out of control. I have proposed just this question that always comes up for me, and that has to do with what do you do when you've exceeded your 8 or 12 puffs based on the age, and now you're on your way to the emergency room and you don't have any albuterol and you don't have any puffs left. Actually, it's okay to give additional puffs of ICS formoterol if you are en route to an emergency room. And as you can see, our action plan says you can have up to 6 additional puffs if you are en route. And so I think these are things that our action plans need to address as we learn to do practical, helpful points to families that have asthma. So, and this is from the Allergy and Asthma Network. It is a advertisement or cute little picture that actually says to families as they visit this particular website, if you don't have an asthma action plan, you should ask for one. You should know where it is. Potentially take a picture of it and keep it on your phone so that you were like, oh, but it's back at home, it's on the refrigerator, oh, I don't remember where I put it. I try to remind my patients to have it in a place like their phone that's very visible so that they can refer to it even though they may have mild asthma and think they're never going to need it. Remember, 27% of asthma mortality are in patients who have mild persistent asthma. So you never know when you're going to have a bad attack. And then I always say bring it to your appointment so that we can see how you interpret it, review it, and also make sure that if we need to update it for the school year, we could see that it is expired. Ideally, they would be scanned into the EMR, but that doesn't always happen. And then I, again, think that as time moves on and we get more EMR systems that are able to adjust, that ideally having the patient be able to go into the EMR and print their asthma action plan will be very important. And again, I think it's important that we tailor these for different literacy levels and that we make sure that potentially, in addition to making sure that they have their medicines, that we also address other social determinants of health that do impact how well our asthma patients are managed. And then we need to make sure that everybody knows what the action plan is and everyone who cares for these individuals have access to those action plans. So what I'd like for you to take home from this is that even the right medicine, if we don't know how to use it correctly and we don't have it, actually set us up for failure. And again, I want to remind you that if we review the asthma action plan and we make sure they have the medicine and they know how to do it for 20 patients, one patient will have been prevented from a hospitalization if we actually do that for our patients. And I think it's very important that we do educate. We should check the inhaler technique every time and make sure that there's an asthma action plan available at each visit that we see the patients. And there are some additional resources here. Again, there's a QR code that reviews how to correctly use your devices at the Allergy and Asthma Foundation of America. And then also, if you go to the Allergy and Asthma Network, there are a whole slew of action plans that are available there. And you could probably find that will suit your practice and help you be able to give patients the right action plan. And I think I did it with a minute left before my 10 minutes for questions were up. So I do want to, though, tell you that the Allergy and Asthma Network does have another webinar if you enjoyed this one. And it's coming up in September. And it is diagnosis and management of options for mast cell disorders, which many of us find very challenging to manage, and that's on September 10th. So I appreciate very much the opportunity to talk very fast to you all, and I look forward to see you all around and about and answering some questions now.
Thank you so much, Dr. Hogan, for that extremely informative presentation. I have a couple questions for you today. The first question is, at what age is it okay to switch from a spacer with a mask to a spacer with a mouthpiece?
So part of that is dependent upon the child. Obviously, if you have a special needs child, we're going to end up doing a mask for many, many years. I tend to switch over right around, and this is totally just my clinical experience. I tend to change it over around about age 9 or 10 if I have a very good child who is able to coordinate it. But I watch first, and sometimes I even go in with both a mouthpiece and a mask, and I make sure that they can do the mouthpiece spacer device well first. And I even encourage high school kids, even though they could technically not use a spacer, to still use a spacer, because I think it more effectively sends the medicine where it needs to be. But around about the age of 9 or so, and that's pretty arbitrary, but that's about when I start to think about it, 8 or 9.
Thank you, Dr. Hogan. The next question is, if there's a noise heard using the holding chamber, are they breathing in too fast with that one as well?
So in general, neither one should make a noise. So if you have your holding chamber, either other than, I don't really think you can hear the flap. If you've got really supersonic hearing and you can hear the flap move, that's okay. But if you hear a whistle or you're hearing a noise, the technique is not correct. In general, the biggest noise we hear are the ones that have the mouthpiece, and they'll whistle. And clearly, if they whistle, I say, doesn't count, got to do it again.
Thank you. Where would a person get an asthma peak flow monitor?
So usually asthma peak flow monitors are usually provided by your physician at the office if they have one. They can write a prescription for them. They are available, I think, on Amazon. And I think there's actually also don't quote me on this, but it used to be a link at Allergy and Asthma Network that you could get a peak flow. They're not necessarily a prescription. You could get them over the counter. Again, but you need someone to set it for you. So you need to know what your correct numbers are for your particular, it's based on your height. And then it's also based on how well you could breathe. So in the old days, we used to take it in the room. We used to have them blow it 4 or 5 times. We'd average for their best, and we'd say, this was your best. In general, they are not, they can be helpful, but they can be manipulated. And so we really don't rely on them as much as we used to. We really more ask questions about how are you doing clinically? Are you coughing? Are you having problems when you exercise? Are you having problems when you wake up? We're really more focused now on symptoms than necessarily peak flow monitoring. There are some select patients we use it in.
Thank you. Another question that we just got in the chat was, if it whistles and doesn't count and you have to do it again, does that mean another puff of the inhaler?
Yes.
Okay. Great. And a question we had, have you seen kids continuing to use a spacer and mask into teenage years? I think you touched on that just a moment ago.
Yeah, absolutely. And in fact, my daughter, who's 25, who has asthma, I'm like, honey, use a spacer, and she does. And she's like, I feel better, I get it better. And you know, certainly if you're in the throes of a significant asthma attack, it's really hard to generate enough force to use your inhaler correctly. So certainly in those individuals that have frequent exacerbations, you absolutely want to make sure that they get the medicine where it needs to be, and they may not be able to time it correctly without a spacer. So in general, if they can afford a spacer, I think spacers are the best way to go.
Thank you. If there was a myth to bust, what would be a myth buster that you'd like to talk about?
Oh, Mythbuster. Oh no, this is, I think I covered most of my myths, but
Yes.
I think that probably would just basically be if I were a provider that this patient has had asthma for a really long time, and I'm certain that they know how to use their spacer and inhaler, and that I don't need to review it. People forget, and it's so critical to review it. And again, it's so important that Gina says it over and over again. They need to have action plans, and they need to know how to use their devices. So my myth would be don't trust anybody to say, yes, you really do know how to use it without reviewing it with them again.
That was great. Thank you so much. We'll end here. I really appreciate your time today, Dr. Hogan.
Thank you,
In a few
everybody, for
days-
coming.
Yes, thank you. In a few days, Zoom will email you a link to the recording and evaluation and supplemental resources. And again, on her screen, Dr. Hogan has our next webinar, which will be with Dr. Lyons, pathophysiological of mast cell disorders, focusing on their clinical manifestation, diagnostic challenges, and differential diagnosis. Dr. Lyons will share the latest advancements in biomarker identification, diagnostic testing, and therapeutic approaches, including pharmacological treatments and lifestyle modifications. And then we have a non-CE webinar later this month on understanding and managing contact dermatitis, and we'll be joined by the allergist and pediatric expert, Dr. Alma Alexis, for focused training designed for clinicians involved in allergy and dermatology care. This webinar will involve evidence-based approaches to improve patient communication, adherence, and personal treatment. Patients and physicians are welcome to attend. And that is the end of our webinar today. Thank you all. You'll receive a post-webinar email shortly, and have a great day. Thank you.